Recording.
Give it now. Not for you.
Thank you very much. ಏನಿಲ್ಲ ಫಿಕ್ಸಿಂಗ್ ಏನಿಲ್ಲ
Good afternoon, all the SARS members. I welcome all the SARS members for the today's, that is the fourth online clinical meet of this year. Today we have with us Dr. D.G. Tadikoti sir, Professor, Department of Anesthesiology as our chairperson. Welcome sir. We have interesting cases from Department of Pediatrics, Radiology and Anesthesiology. I'll hand over to sir. Please carry.
Thank you. Dr. I thank their chairman and secretary of ACRS for giving an appointment to chair this session. So let's start with the time. The first one is I call upon Dr. Tanmaya Thagaraj, Pediatric Department.
Good afternoon, everyone. Today I'm going to present the paper titled Trial of Intrapleural Streptokinase in Children with Empyema. It was done under the guidance of Dr. J. Prakash, Dr. M. Patil, Dr. S. S. Kalyan Shetty, and Dr. S. A. Patil sir. Childhood pneumonia can complicate to form empyema thoracis. Although mortality is low, morbidity is significant. Incidence is 0.7 to 3.3 per lakh population worldwide. Antibiotic treatment and adequate drainage is the mainstay of the treatment. Increased production of fibrin results in formation of loculations and septations within the chest cavity, in complicated cases resulting in ineffective drainage. It is unclear whether optimal management is closed tube drainage or video-assisted thoracoscopic surgery, followed by chest tube drainage. In failure of medical treatment, open decortication is often needed. In such cases, intrapleural fibrinolytic agents are employed to avoid thoracotomy. In our hospital, there was a 2-year-old boy who presented with cough and fever for more than a week and hurried breathing since 2 days. Clinical examination and chest X-ray were suggestive of right-sided pleural effusion. Pleural tapping was done, which showed pus. CECT showed right-sided empyema with underlying collapse consolidation. IV antibiotics were started. ICD inserted and frank pus collection obtained. Repeat USG showed persistent collection. Intrapleural injection streptokinase instillation was done. It was done once in a day and was given for total of 7 days. Child had 4 days of ICU stay and discharged on 12th day. Child showed remarkable clinical and radiological improvement. This is his first X-ray when he was admitted, and this was on the 7th day after installation of streptokinase. Case 2, a 6-year-old male child brought to PICU had complaints of fever for 10 days, cough since 8 days, and breathlessness since 2 days. Clinical evaluation suggestive of left-sided pleural effusion. Blood examination, chest X-ray, and pleural tapping was done, followed by CECT. He was diagnosed with left-sided loculated empyema, treated with IV antibiotics, oxygen therapy, and ICD drainage was done. Again, repeat USG showed loculated pus collection. He was started on injections given intrapleurally. Clinically and radiologically, he was improved, and he stayed in hospital for 15 days. This is the image of the child, the CCT image, and this is the X-ray discharge. Case 3, a 5-year-old male child came with complaints of cough and cold since 8 days and fever since 7 days. Further clinical laboratory and radiological evaluation was suggestive of right-sided empyema with loculation.
ಮ್ಯಾಮ್ ಅವ್ರದ್ದು ಇಲ್ಲಿ ಕೆಳಗೆ
ICD tube was inserted, pus drained, and serial USG monitoring done. In view of persistent pus with septations, he was started with injection streptokinase, given intrapleurally for 5 days, clinically improved, and was discharged after 12 days of hospital stay. This is his ICD tube collection and X-ray on the last day of streptokinase installation. So in the case 1, they were, almost all the symptoms were similar, which is cough for 10 days, fever over more than a week, and hurried breathing. On blood investigation, it was suggestive of infection present. Total count 10,150, hemoglobin 9.8, PCB 27.6%, platelet 3.58 lakhs, ESR was raised, and CRP was more than 90. And radiologically, right-sided pleural effusion was present. Pleural fluid analysis showed 1.2 lakh cells, which was 99% of neutrophils, and ADA was 32. Gram stain and ZN stain was negative. ICD tube was inserted on day 2 of admission, and streptokinase was started on day 3 of admission and was totally given for 7 days. Case 2, fever for 10 days, cough 8 days, breathlessness 2 days, and total count was raised 34,820, hemoglobin 10.9, PCV 32.6%, platelet count 5.53 lakhs, ESR was high, 107 millimeter in first hour, CRP was more than 90. On pleural fluid analysis, 76,800 cells were present, 98% of them were neutrophils, and ADA was 18. In this, gram stain was gram-positive cocci was present. Injection, ICD was inserted on day 1 of admission, and day 2 of admission, injection streptokinase was started, and 7 days continued therapy. Case 3, cough and cold for 8 days, fever 7 days, total count 7,540, HP 12.2%, PCV 35.7%, ESR 43, and CRP raised more than 90. Here, total count was in pleural fluid was 15,000, 60% of them were lymphocytes, ADA was 36. ICD insertion on day 1 of admission, streptokinase started on day 3 of admission, was given for 5 days. So, forms on the pleural surfaces, and fibrillopleurine phase where fibrinous septa form causing loculation and thickening of parietal pleura, and organization phase where it prevents expansion of lungs. Though empyema thoracis in children carries little or no mortality as compared to adults, it causes many morbidity and complications. If pus is not drained in the second phase, it may dissect to the pleura into lung parenchyma, leading to bronchopleural fistula, pneumothorax, and it may lead opening into abdominal cavity or through the chest wall. If organized, lung may collapse and become surrounded by thick inelastic field. In our hospital, we have administered 15,000 international units per kg per dose of injection streptokinase intrapleurally through the ICD tube. It was made to retain inside the pleural cavity for about 4 hours, and then the fluid was allowed to drain freely. It was given once in a day for 5 to 7 days duration. Intravenous antibiotics and supportive management were continued as per unit protocol. Chest drain was removed on clinical and radiological improvement when less than 1 ml per kg per day of fluid was drained. In a study conducted by Bose and others in Kolkata, 28 patients were studied, of which only 2 required surgery and 26 responded to injection streptokinase intrapleurally. Streptokinase benefited both in early, that is within 7 days of symptoms, and late starters, which streptokinase was started after 7 days, and there was no statistically significant difference in outcome regarding benefit of streptokinase among the early and late starters. A study done by Joseph, Matthew, and others concluded that intrapleural streptokinase was effective for multiloculated empyema even when it was administered more than 14 days after the disease onset, and 4 to 6 doses were superior to the 3 doses, and median hospitalization duration was shorter with 4 to 6 doses rather than 3 doses. Option for drainage is controversial. Some believe that video-assisted thoracoscopic surgery followed by chest tube drainage is effective, and some experts opine in favor of closed tube drainage with or without fibrinolytics. Some think of early decortication. A recent meta-analysis of 10 trials reported that intrapleural fibrinolytics reduced the need for surgery and duration of hospitalization. Streptokinase was the first fibrinolytic agent described by A and others. It is a purified proteolytic enzyme derived from bacterial protein of beta hemolytic streptococci group C. Plasminogen is converted into active form of plasmin by streptokinase, and this plasmin degrades the fibrin clots and fibrinogen. In our cases, all children who received intrapleural streptokinase have improved without any sequelae, and we could avoid thoracotomy in this case. These were my references.
ಡೇ ಅಂತ ಹೌದ್ರಿ
Thank you.
Thank you, Mama. It was very exercise and nice. It is now for
The 3 patients were in which stage of empyema?
So they were all in fibrinopurulent stage, the stage 2.
Which patient has in the third stage? One with the online, like one with the
Initially, there was ICD tube drainage in this patient, but the drain was reduced, and we did repeat USG where we could see oculation separations present, and then we started with streptokinase.
what is in the ideal stage? At which stage streptokinase should be used? Stage 1, stage 2, stage 3.
In stage 2, we can use it because there is fibrin formation in stage 2.
What is the take-home message?
Ma'am, in children who empyema, when it complicates, we go for open decortication. This can be avoided with medium fibrinolytic intrapleural.
If you need a series of cases, what is the purpose? 20-25 cases.
We are continuing. We started recently, we are continuing study. Thank you.
So, thank you. Great. The next person is Dr. Sai Krishna Prasad from Department of Anesthesiology.
If the doctor take your time, you will 5 minutes time, and take 1 minute extra. Don't take much time. More than that. Don't take your time.
Good afternoon. I'll be presenting a case report of anesthetic management of Epstein's anomaly posted for emergency LSAs. Epstein's anomaly is an uncommon complex congenital malformation of the heart with prevalence of 0.3 to 0.5%. It occurs in 1% of the congenital heart disease cases. It is characterized by dysplastic abnormalities of tricuspid valve, which involves both basal and free attachments of the tricuspid valve leaflets. It is downward displacement and elongation of the septal and the anterior cusp, resulting in tricuspid regurgitation. The proximal part of the right ventricle is atrialized, becoming thin-walled and poorly contractile, along with an enlarged right atrium. Patients can have a highly variable clinical course related to anatomic abnormalities of Epstein's anomaly and their hemodynamic effects or associated structural and conduction system diseases. These include atrial septal defect, ventricular septal defect, pulmonic stenosis, tricuspid atresia, pulmonary hypertension, ventricular and supraventricular tachycardia, and Wolff-Parkinson-White syndrome. Cyanosis, pulmonary and systemic emboli, congestive cardiac failure, and sudden cardiac collapse are anticipated complications. Maternal mortality due to Epstein's anomaly is considered to be less than 1% in asymptomatic patients, but may be as high as 5 to 15% if aggravated by conditions like supraventricular arrhythmia, Wolff-Parkinson-White syndrome, or atrial fibrillation. Case report: 22-year-old female admitted on 18/1/2020. Came with 9 months of amenorrhea and diagnosed with Epstein's anomaly outside, came for safe confinement. Patient was apparently normal 5 months of amenorrhea and was incidentally diagnosed of Epstein's anomaly during routine checkup. There is no history of any breathlessness, giddiness, blurring of vision, or palpitations. No history of any PVD, pain movement, or PVD. Patient was started on tab metoprolol 25 mg OD when diagnosed with Epstein's anomaly. Started on tab labetalol 2 days prior to admission in view of gestational hypertension. Clinical examination: moderately built, well nourished, well oriented place in time. There was no pallor, icterus, cyanosis, lymphadenopathy was absent. Pulse rate was around 64 per minute and BP was 150/90. On CNS examination, S1, S2 was heard. There was systolic murmur heard in the left parasternal area and there was no parasternal heat. And RS examination showed normal vesicular blood sounds bilateral. Provisional diagnosis: primary gravida with 41 weeks period of gestation with gestational hypertension with Epstein's anomaly, posted for emergency LSCS in view of oligohydramnios. Investigations: hemoglobin was 11 grams per deciliter, total count was 11,400, and platelet was 2.18 lakhs. Coagulation profile was within normal limits. BT was 1.30, bleeding time was 1.30, clotting time was 5.45, and INR was 0.80. Renal function test: serum creatinine was 0.8 milligram per deciliter and blood urea was 26 milligram per deciliter. 2D echo report showed moderate TR with a gradient of 30 mm Hg. Apical displacement of septal and tricuspid leaflet. Tethering of lateral tricuspid leaflet. Right atrium and right ventricles were dilated. Small ostium secundum, left to right shunting, and a normal LV systolic function with a left ventricular ejection fraction of 60%. Management: intraoperative management. Patient was shifted to OT. Pulse oximeter, ECG, and non-invasive blood pressure was attached. A 20 gauge IV line was secured and intravenous fluid lingaractate was started. Patient was turned to the left ventricle position. Painting and draping was done as per protocol. Spinal anesthesia was administered using 25 gauge spinal needle in the L3 L4 lumbar space. Injection bupivacaine 0.5% to 25 microgram of injection fentanyl was administered with a total volume of 1.8. Patient was turned to supine position and subarachnoid block was assessed. After adequate block was assessed, a wedge was placed on the right buttock. Intraoperative BP, pulse rate, and ECG was monitored closely. After delivery of the baby, injection oxytocin 10 international units were administered by IV infusion. No further doses were repeated after confirming sufficient uterine contraction. Intraoperative period was uneventful and patient was shifted to post-anesthetic care unit. Patient was monitored for 12 hours post-operatively. The post-operative period was also uneventful. Discussion: in the presence of an Epstein's anomaly, there is impaired right ventricular size and function, further deteriorated by increased blood volume and cardiac output during pregnancy. Hemorrhage along with excessive fluid resuscitation is generally poorly tolerated. The presence of arrhythmias, cyanosis, or preeclampsia are associated with increased maternal and fetal risk. 2 to 14% of the babies born to mothers with Epstein's anomaly have congenital heart disease. The combined effect of increased circulating catecholamine, maternal hemodynamic instability, and maternal hypoxemia in mother with congenital heart disorder is associated with a poor neonatal outcome. The basic principle for anesthetizing a patient with cardiac disease are maintaining both afterload and preload along with the sinus rhythm. General anesthesia, the disadvantages include there's more risk of aspiration, increased catecholamine levels, increased right to left shunting, and increased intrathoracic pressure. Now coming to regional anesthesia, the advantages provided by regional anesthesia include minimal fluid shift, minimal catecholamine levels, control of metal hyperventilation, post-operative analgesia. Among the regional anesthesia, epidural anesthesia is a better choice, but has a disadvantage of requirement of more time and more skill to establish a epidural catheter. So in case of emergency sections, it would not be the best choice in case it is fetal distress or oligohydramnios. The hemodynamic stability offered by epidural anesthesia can be achieved by administering a low-dose subarachnoid block of spinal anesthesia with an adjuvant. Thank you.
Good presentation. Thank you. Open for the
Rasam was there. Chapati.
Any cardiac disease, normally, GA is better than renal.
Yes, sir. Generally, GA for cardiac diseases, we would go on for general anesthesia, sir. But here in this case, what the problem is, the patient does not tolerate volume overload, tachycardia, or hypotension. So and this inhalation anesthetics can lead to hypotension, and during intubation there might be catecholamine. The stress response can lead to further tachycardia, which can put stress on the heart and can lead to right to left shunting. But even in spinal anesthesia, giving a large dose can lead to hypotension, sir. But here we have given low dose, so we have controlled the patient's BP. There was no rapid fall in BP, so there was no tachycardia. So we didn't overload the patient with fluids also. Whereas with epidural would have been the best choice because the fall in BP after administering an epidural anesthesia is slow. So there would be no rapid fall and there would be no tachycardia. But the problem with epidural anesthesia is it needs a lot of time to secure the epidural catheter, and it requires a lot of skill also. And pregnant ladies tend to have a very edematous spine region. It would be very difficult. And other case reports and references have tried this, and almost like 50% of the patients have had dural puncture with epidural catheters, which has led to post-dural puncture head in almost 85% of the cases which have had epidural anesthesia for such Epstein anomaly cases.
Which are the other heart disease which there is no block happening there? In the spinal head. In general, general anesthesia safer than any cardiac.
Yes, sir. It actually depends on the left ventricular ejection fraction and all the factors, sir. Like there is no particular this thing that for this particular disease you can give spinal. It depends upon the 2D echo of the patient, and if the patient is having any signs of congestive cardiac failure and all that, sir. Like if a patient with rheumatic heart disease say has a good left ventricular ejection fraction, and there is no say clot or emboli in the valve, we can still try to give spinal anesthesia, sir.
Traditionally, you or whatever it is, there is a tactic. Here we are given a reason. That is how patient is totally stable. We make a normal person. In severe section, patient is fine. That is fine. Reason. Probably we can select the reason to avoid the complication.
Yes, sir.
Your patient has any symptoms.
The patient was asymptomatic, sir. So
Very asymptomatic.
she was incidentally diagnosed also. So that is why we went ahead with spinal. Thank you.
Thank you. The next presentation is by Dr. Sayed right here from Department of Pediatrics.
Good afternoon, everyone. I'm reporting a case report, fetal inflammatory response syndrome in newborn water co mother, first of its kind. Vertical transmission of SARS-CoV-2 in a neonate is suspected if a mother is positive of SARS-CoV-2 between 14 days prior to the birth and 12 days after the birth, and virus is detected in any of the following samples in first 24 hours. Following samples: neonatal respiratory tract, so amniotic fluid, umbilical cord blood, or neonatal blood sample. Neonatal SARS-CoV-2 infection is asymptomatic in majority of the cases and presents with fever in few patients. Coming to the case report. Here is a preterm neonate, born to a mother of primary gravida, 32 weeks gestation rate, delivered by LSCS, of birth weight of 2 kgs, with a history of PPROM, that is preterm premature rupture of membrane, was present of 8 hours duration. Mother had received antenatal steroids before LSCS. Baby cried immediately after birth, of a birth of 8 at 1 minute and 9 at 5 minutes respectively. Presented with the respiratory distress at 1 hour of life. At admission, neonate had tachypnea, that it had a 77 respiratory cycles per minute, and grunting was present, and with the Silverman Anderson scoring, that is scoring for tachypnea of 3 by 10. And on doing a chest X-ray, there was bilateral symmetrical ground-glass appearance and bell-shaped thorax, which is characteristic white lung of respiratory distress syndrome in a preterm neonate. Was in an NICU. Baby was put on CPAP with a PEEP of 5 mm of Hg with a FiO2 of 40%. Maintenance IV fluid and first-line antibiotics were started as per our protocol. After 5 hours of life, cyanosis of the right lower limb with diminished pulses were noted. Initial sepsis screen revealed leukocytosis. Total count was 16,350 with neutrophil predominance of 72%, and CRP was negative initially. Over the next 24 hours, respiratory distress worsened with the increased oxygen requirement, and we ventilated the patient. This was the right lower limb, which continued to have cyanosis with diminished pulses. Saturation in the affected limb was 70 to 75% at room end. And we performed the color Doppler for the same limb. And we noted that arterial wall thickening with echogenic content inside the lumen of right common femoral, superficial femoral, and popliteal artery was present, which was suggestive of thrombosis. Course in our NSU, PT prothrombin time and activated prothrombin time was prolonged with elevated CRP, ferritin, elevated LDH, and elevated DNA mass. Low molecular weight started immediately, and low molecular weight along with the vitamin K was continued for 3 to 4 days. And 1 alicot of FFP was transfused. On a day 2 of life, we sent a serology for COVID-19 on a light of ongoing pandemic of COVID-19. IgM and IgG for COVID-19 turned positive, and nasopharyngeal swab was sent on SARS-CoV PCR testing, which detected negative in a baby. And followed by, we sent in a nasopharyngeal swab for mother for SARS-CoV-2 PCR testing after discussion with obstetrician, which was detected positive, and baby was immediately shifted to the COVID-19 isolation in ICU. After 48 hours of starting enoxaparin, low molecular weight heparin, the color of the right lower limb improved and appeared pink, except the forefoot and the toes, which continued to look blackish. That was ongoing gangrene was present. On day 3 of life, we started the tropic feeds, continued conventional ventilation in SMAV mode with pressure support, with FiO2 of 50% and a PEEP of 12, PIP of 12 and PEEP 5, and a respiratory rate of 35. And day 3 was uneventful. On day 4 of life, neonates antibiotics were upgraded as per unit protocol in view of rise CRP and the total count. 2D echo was done, which was found to be normal. Gradually, we weaned from mechanical ventilation to HHFNC, and then to a room air gradually over three days. Antibiotics discontinued after 7 days because bacterial culture was negative. Baby was discharged after 10 days of hospitalization with advice of infection control at home and hand hygiene and respiratory hygiene. To prevent community transmission, attenders were advised to self-quarantine at home. Discussion. SARS-CoV-19 2 is a single-stranded RNA virus belonging to the genus beta coronavirus, transmitted across the human primarily through respiratory droplets and contact. in literature regarding the vertical transmission of the SARS-CoV-2 is sparse, with a majority of the studies indicating horizontal transmission only. In our case, in our case, early onset COVID-19 disease in a neonate was probably acquired by vertical transmission, bar secondary to the fetal inflammatory response syndrome. A study by Vivante and AJ et al. And others reported vertical transmission acquired transplacently in a preterm neonate. Earlier studies have failed to reveal the maternal and fetal transmission of SARS-CoV-2, including the negative testing in amniotic fluid, umbilical cord, blood, vaginal swab, and breast milk. 2 neonates were tested positive for RT-PCR for SARS-CoV-2 within 30 hours of life, have been reported similar to our case. Most neonates present between day 5 to day 28 life has documented till date. Fever in the main presenting symptom in COVID-19 in neonates with favorable prognosis. That was the main symptom in 66% of the neonates. In our case, neonates presented at 1 hour of life was tested positive for serology by 30 hours of life. We suspect COVID-19 in the light of ongoing pandemic, where a present complaint was thrombosis in the right lower limb due to coagulative abnormality, which was never reported till date in neonates. There are reports of thrombotic complication contributed to mortality and morbidity in adult COVID-19, but not in pediatric patient. Among 11 published cases, neonatal COVID-19, 8 of the neonates were born to a mother who tested positive for COVID-19, as quoted by Dampa and others. In our study, a mother was retrospectively assessed after neonates report and found to be positive for RT-PCR and serology. Frequent laboratory abnormalities seen in case of COVID-19 include lymphocytopenia, thrombocytopenia, leukopenia, and elevated inflammatory markers. In our case, leukocytosis followed by leukopenia with elevated CRP, ferritin, D-dimer, and elevated LDH was present. Dampa, we and others postulated that neonatal infection can be early onset neonatal infection, that is first day to 3 days of life, or late onset neonatal infection, that is from 4 to 28 days of life. Our case fits into the early onset category, probably due to vertical transmission. Perinatal, coming to the fetal inflammatory response syndrome, perinatal fetal disease is a potential complication of neonatal born to mothers infected with SARS-CoV-2. FIRS is associated with otherwise unexpected preterm birth, as in our case. FIRS stimulated by a maternal viral load explains the perinatal depression and subsequent metabolic acidosis and severe PAH. Even in the absence of vertical transmission, FIRS due to maternal SARS-CoV-2 infection could lead to significant neonatal morbidity. In infants born to a mother diagnosed with COVID-19, SARS-CoV-2 associated FIRS should be considered in all neonates. Postnatal transmission is extremely unlikely in our case, as neonate was separated immediately after the LSCs. Though the gold standard for SARS-CoV-2 is RT-PCR, some articles reported false negative rates between 2 to 29%. Majority of the cases due to horizontal spread has reported previously by Chan and others, except few cohort studies. There is no evidence to suggest that this infection can be transmitted through breast milk. Currently, literature suggests the possibility of vertical transmission of SARS-CoV-2 is unclear, except for few case reports, including our study. The most common mode of neonatal transmission of COVID-19 seems to be horizontal, while vertical transmission is likely in early onset infection. Thrombosis of the peripheral artery involving digits should raise the suspect of COVID-19 in all neonates. This might be the first such case in neonates reported till date. Conclusion: this is the first of its kind, not reported anywhere else in the world, anywhere else till date. This emphasizes the need of further research into the mechanism of transmission of SARS-CoV-2, that is vertical transmission from mother to baby. We have successfully managed the respiratory distress syndrome, preterm care, arterial thrombosis of right lower limb with a COVID-19 positive status in neonate. And this article has been accepted in Scopus Index International Iranian Journal of Neonatology. This is our team's comment.
Thank you. Nice presentation. Now we can open for
Congratulations to you for the management of the case.
Thank you.
What happened to the ongoing early?
That gradually improved, sir. Limb became normal and No, sir. No. Like adult, we didn't start any other medication except our routine neonatal care treatment. First line antibiotics, second line antibiotics. That was to after antibiotic blood culture became negative. We have stopped that after 8 days of life. Sir? Respiratory distress was there, sir. Preterm birth, that may be also due to the maternal COVID-19 infection, sir. And the right lower limb arterial thrombosis was there.
In the first slide, you mentioned where is 12? You said 12 days, but it is written as
14 days prior to birth and 2 days after the birth.
you said 12.
No, 2 days. After 48 hours after birth. No, we are not going. And the recommended dosage is also not this. All are under trial. We have used in 3 to 5, one case for 3 to 5 year olds. No, we have only for one cases right now we have used, but it recovered well also. But actual guidelines. Thank you, sir.
Thank you.
Thank you. Next presenter is Dr. Amrut from the Department of Radiology.
Good afternoon, everyone. Myself, Dr. Amrit. I'm second year PG resident in the Department of Radiology. I'll be doing the case presentation under the guidance of Dr. Shivanand Patil, Dr. Satish Patil, and Dr. Ravi Kumar. Coming to the history of the patient, a 85-year-old male presented to the OPD, surgery OPD with complaints of swelling appreciable since 15 days on the posterior lateral aspect of chest wall on left side. And on examination, the swelling was mildly tender, firm in consistency, and measuring about 5 to 6 centimeters in size. The patient also complained of generalized weakness and loss of weight since 6 months. There's no history of trauma, alcohol intake, smoking, or diabetes mellitus. And there's no evidence of clinical cervical lymphadenopathy. So the patient was referred to the Department of Radiology for further investigations for basically chest plain and contrast. On imaging findings on chest X-ray, PA view, a large well-defined homogeneous soft tissue mass lesion was seen arising from the 7th rib, causing its destruction in the posterior lateral aspect of chest wall on left side. And this is the X-ray where you can see the homogeneous mass seen on the posterior lateral aspect of the left side of the chest, which is causing destruction of the adjacent rib. On non-enhanced CT, there is evidence of ill-defined multi-lobulated frond-like soft tissue density mass lesion measuring about 81 into 68 into 79 mm in the posterior lateral chest wall with intra and extrathoracic component involving the intercostal muscles and causing its destruction of posterior lateral aspect of 7th rib and lateral aspect of 6th rib. The lesion is limited by serratus anterior muscle posterior laterally and the parietal pleura medially. The lesion was also seen abutting the left lung, parenchyma, and parietal pleura. So this is the soft tissue density mass lesion, frond-like, and laterally it is limited by the serratus anterior, posterior laterally, and medially it was limited by the parietal pleura and the adjacent lung parenchyma. And this is the coronal section where you can see the same soft tissue density mass lesion. And coming to the another lesion, there was another similar lesion noted in involving anterior aspect of chest wall on left side, measuring about 29 into 28 into 31 mm with dissection of the sternum on left side and left fourth and fifth rib at sternocostal junction. This is the another lesion, similar lesion. On the basis of these findings and age, that was 85 years old male, the differential diagnosis of chondrosarcoma, since it was involving the sternocondral junction, chest wall metastasis, and multiple myeloma was made. And there was evidence of diffuse osteopenia with multiple lytic lesions involving the ribs, sternum, and thoracic spine was noted. These are the hypodense bones which are seen. Depending on the Hounsfield units, we can make out whether the bone is osteopenic or not. And coming to the contrast enhanced CT, the mass showed heterogeneous enhancement on post-contrast study with central non-enhancing necrotic areas within. So these are the non-enhancing hypodense, non-enhancing necrotic areas within. With the presence of diffuse osteopenia, multiple lytic lesions in the ribs, thoracic spine, a provisional diagnosis of multiple myeloma was made. Hence, we took a skull X-ray, AP, and lateral view, and advised for FNAC and chest wall of the chest wall lesion. This was the X-ray of the patient. The skull shows multiple well-defined, radiolucent, punched out, round, variable-sized lytic lesions involving the skull vault, well appreciated on the lateral view, giving a raindrop appearance to the skull. And the FNAC was done from the posterior lateral aspect of the chest wall lesion. That is the bigger one. It showed multiple smears. Study shows scanty to moderate cellularity, composed of variable sized mature and immature atypical plasma cells, arranged singly and in clusters with varying pleomorphism. Atypical plasma cells have centrally eccentrically placed nuclei with finely dispersed chromatin and few showing nucleoli. Perinuclear halo seen in few cells. Occasional binucleation of the cells was seen. The bone marrow aspiration was done and shows 50% of the 50% of plasma cells. For diagnostic criteria, we basically use more than 10%. And the urine was sent for the investigation, and it showed positive for Bench Jones proteins. With all these findings, the final diagnosis of multiple myeloma was made. Coming to the discussion, multiple myeloma is the most common primary bone marrow malignancy in adults. Most plasmacytomas arising from the bone are osteolytic in nature and usually do not contain intralesional calcifications. The differentials to be considered in this patient is chondrosarcoma, chest wall metastasis, and multiple myeloma. Chondrosarcomas are malignant cartilaginous tumor, most commonly seen in the older patients, and they are often seen involving the sternum and costochondral cartilage in case of chest wall lesions. These lesions have ring and arc type of calcification, which was absent in our patient. Expansive osteolytic chest wall metastasis can be the most common primary and which we consider first differential. But since the most common metastasis to chest wall lesions are from renal and thyroid, screening was done by USD, but and was ruled out by screening ultrasound. Conclusion: multiple myeloma presenting as chest wall lesion is rare. Radiological imaging plays an important role in providing provisional diagnosis and the extent of the disease, and to make the future complications. FNAC and biopsy is required to come to a final diagnosis. And these are the references.
Good presentation.
Thank you.
Now topic is for discussion.
Yes, there is both. MRI actually gives a more clear idea about the extent and the staging of the disease. CT is like the anatomical wise, you can more appreciate the extent of the disease. And on MRI, we can do like, since we can do whole body MRI, where we can thoroughly scan the whole body, where we can make out any lesions anywhere in the body. On CT, and the disadvantage with CT is you can't do the whole body CT because there's increased exposure of radiation to the patient. But in MRI, which is not there, so it is an advantage over CT. Yes, yes, ma'am. Which showed heterogeneous and
only just was the
Chest wall lesion appreciated since 15 days, sir. Yes, sir. Yes, sir. Initially, when we suspected metastasis, sir. Since at the old age, the most common presentation will be metastasis. But since heterogeneous enhancement and we ruled out by screening, we ruled out any thyroid and renal malignancies. So, and other relevant investigations was done and we came to a final diagnosis.
Directly would have gone for snake.
Huh?
You have done before that like normal CT.
Ma'am,
Without contrast.
No, before contrast we take normal, without contrast CT, non-enhanced CT.
Because you are suspecting the malignancy, you would have avoided vertical CT.
No, ma'am, for any mass lesions, before giving contrast, one plain CT has to be taken, ma'am. We take the contrast CT to see the pattern of enhancement, to see whether early wash-in, early washout, delayed wash-in, early washout, delayed wash-in, delayed washout. Depending on that, we'll get differential. Thank you.
Next, we will be going for poster presentation. So, first presenter will be Dr. Lakshmi S. Pillai from anesthesia.
Good afternoon all. My poster is about the anesthetic challenges in the management of a meningomyelocele repair. It was done under the guidance of Dr. Anusha Sultan. Meningomyelocele is a common congenital spinal anomaly which is mainly due to inadequate fusion of the neural tube resulting in the herniation of the neural elements and the CSF. And various other anomalies are associated with meningomyelocele. The anesthetic challenges mainly in such repair in a neonate include intubation with proper positioning to avoid the rupture of the sac, intraoperative prone position ventilation and its complications, maintenance of the anesthesia, temperature control and the fluid management. So in our case, this is a newborn male baby weighing around 3 kg born to a primary mother via spontaneous vaginal delivery, was referred from outside to our hospital in view of meningomyelocele and was shifted to NICU. The maternal history revealed that she was irregular with her antenatal scans, and on examination, the baby had a saturation of 98% with oxygen reacted at 5 liters, with no bacterial malformations and no evidence of Chiari malformation. On a local examination, there was a cystic pediculated swelling of around 6 into 5 centimeter at upper lumbar region. The swelling was covered with cotton pads and the neonate was positioned in a lateral decubitus position. So all the other investigations were within normal limits. The MRI lumbar spine revealed that there was upper lumbar meningomyelocele. The 2D echo did not exhibit any other structural abnormality of the heart. The baby was posted for surgery on 5th day. The monitors were attached in the intro of the cotton pad was placed in the lumbar region to prevent the rupture. The intubation was planned in a supine position. The baseline parameters were recorded. Baby was pre-medicated with atropine, fentanyl, and was induced with sevoflurane, intubated with uncuffed ET tube using propofol and atracurium, and after confirming the bilateral air entry, was placed in a prone position, again confirming the air entry with rolls under the chest and pelvis. And all of the efforts were carried out to maintain a normothermia. Even the anesthesia was maintained, and with the atracurium, fentanyl, and maintenance IV fluid was given. The surgery duration lasted for around 2.5 hours. The intraoperative period was uneventful, and the neonate was turned supine again and reversed with neostigmine and atropine, extubated once adequate respiratory efforts were made, and shifted to NICU for further monitoring. So in this case, the main challenges which are anticipated in our such kind of surgeries is the rupture of the sac due to inadequate positioning, and the challenges encountered during the airway management as a direct pressure on the neural record can increase the intracranial pressure, estimation of the blood loss, the avoidance of hypothermia, increased chances of delayed awakening and the apneic spells. Since our patient was a 5-day-old neonate, all the challenges of the neonate posted for a neurosurgery was omnipotent, and therefore the intra-op also the case was vigilantly monitored. After the neurosurgical repair, the post-operative recovery was also remarkable in this case. So in this, we mainly want to focus attention on the role of meticulous preoperative preparations, vigilant intraoperative monitoring, and the proficient care in the management of the case. Thank you.
Now this topic for discussion.
Routine case of pediatric surgeon and neurologist, meningoencephalocele pain or myelocele or meningoencephalocele. What anesthetic challenges you face?
Sir, usually the anesthetic challenges is because of the difficult airway management, sir. Because of the large lesion in the lumbar region, it's difficult to position the baby in a supine position while intubating. And also there is a problem due to prone ventilation during the surgery. Sorry, sir.
It is routine case for pediatric surgeon and neurologist.
Yes.
Newborn only will be operating. And then 10 days was dead. What extra challenges you face in this case?
Sir, in this case, no, sir, in this case, we didn't have any intraoperative events as such, as all the efforts were taken to maintain a normothermia to position the baby.
Part of pediatric.
Yes, sir.
Different challenges, apart from positioning, extra challenges you have in this case.
So in this case, no intraoperative events was there, sir, because of adequate vigilance. No, sir, no evidence of any Chiari-2 malformations or any other bacterial malformations was there in this baby. Sir, we were suspecting a airway challenge in this kind of situations. Yes, sir, yes. Yes, sir. Yes,
Thank you for the nice presentation. Although it is a routine, we face a lot of many times not that we do really. Next presenter will be Dr. Harish from Radiology Department.
Good afternoon, everyone. This is a rare case of congenitally normal anatomical variant of left renal vein, which is circumeiotic left renal vein. Introduction. Venous anomalies mainly resulting from errors of the embryological development. Venous anomalies of the retroperitoneal region have clinical implications, mainly in retroperitoneal surgeries, in staging of testicular tumors, and in placement of cable fetus. They have also particular importance in situations where extensive dissection of venous system is involved, that is lymphadenectomy. Venous systems are needed for reconstruction, that is transplantation, or invasion of the venous system by cancer is possible. Example, renal cell carcinoma with vascular extension. The development of renal veins is a part of developmental process of inferior vena cava. The process starts from 4th week of intrauterine life and ends at 8th week. These are in the order of appearance. The posterior cardinal veins are the first to appear, then the subcardinal vein and the supracardinal veins. By regression and persistence of these veins, the 4 segments of the inferior vena cava is formed. The hepatic part of inferior vena cava is hepatic part, that is the hepatic vein, hepatic sinusoids. The prerenal part from right subcardinal vein, renal part from anastomosis between subcardinal and supracardinal veins, and postrenal part from right subcardinal vein. The renal veins are formed from the persistence of anastomosis of the subcardinal and supracardinal veins. Both circumaortic and retroaortic left renal veins are the result of persistence of dorsal limb of embryonic left renal vein and of the dorsal arch of the renal collar. However, in retroaortic left renal vein, the ventral arch regresses so that a single renal vein passes posterior to the aorta. Case report. A 17-year-old male, there is a single inferior vena cava ascending superiorly lateral to the abdominal aorta. The left renal veins form a collar around the abdominal aorta. The superior left renal vein passes anterior to the abdominal aorta, just inferior to the celiac artery, and the inferior renal vein passes posteriorly. This is a contrast enhanced axial image of abdomen in venous phase, showing this is the superior left renal vein, which is passing anterior to the aorta, and a lower section, a caudal section, which is below that level, shows another left renal vein which is passing posterior to the aorta. This is a circumaortic left renal vein. You can see the sagittal section where two renal veins are going, one anterior and one posterior to the aorta. This is the anterior superior left renal vein, and this is the posterior inferior left renal vein. Color Doppler study also showed two veins, one running anterior and one running posterior to join IVC. This posterior one is called the retroaortic, and this anterior one is called the preaortic left renal vein. Again, the same images showing the retroaortic. This is the retroaortic left renal vein passing posterior to the aorta, and another vein superiorly which is passing anterior to the aorta. Sagittal and coronal images showing retroaortic left renal vein. Discussion. The inferior vena cava is formed from three parallel veins that are subsequently appear and regress. The posterior cardinal veins, the subcardinal veins, and the supracardinal veins. The posterior cardinal veins are to develop first, being the vessels of mesonephrons, and largely disappear with transitory kidneys. The subcardinal veins appear by the 5th week, lie in plane vertical to the aorta, and the supracardinal veins lie in a plane dorsal to the aorta and are interconnected by a network of veins forming a venous collar around the aorta. The left renal veins develop from the anastomosis of the subcardinal and supracardinal veins. Two renal veins form as ventral and dorsal. The dorsal vein usually degenerates. The ventral vein forms the renal vein. Circumaortic renal vein is caused by the persistence of the supracardinal anastomosis, left subsupracardinal anastomosis, and the left dorsal renal vein. Two renal veins are present. The superior vein passes in front of the aorta at the level of L1 vertebra. The inferior vein runs downward and medially behind the aorta, draining into inferior vena cava at level of L12 disc level. Retroaortic vein is noted to be of two types. Type 1 develops from persistence of the left supracardinal anastomosis, the intersupracardinal anastomosis, and the dorsal left renal vein, with the degeneration of the ventral renal vein. Type 2 is formed by the persistence of the left subsupracardinal anastomosis and the left supracardinal vein. Diagnosis of the left renal vein anomalies is important information in retroperitoneal surgery because the unawareness of this situation in retroperitoneal surgery can result in bleeding, nephrectomy, and even death. The risk of venous injury is higher in patients with a circumaortic renal collar than in those with an IVC anomaly. The large anterior component of the renal collar can easily mislead the surgeon to think during operation that the development of left renal vein is normal and that there is no retroaortic component. The posterior component usually runs obliquely dorsal to the aorta, entering the IVC, caudal to the entry of anterior component. Left renal vein is preferred due to its length in renal transplantation. Because of this, it is important to know the course of the left renal vein, whether it is pre-aortic or not. It is also important to know anomalies of renal vein for distinctive diagnosis of retroperitoneal lymph node pathologies in patients with renal or testicular tumors. The conclusion, detailed knowledge about congenital anomalies of left renal vein is important to make distinctive diagnosis of retroperitoneal lymph node pathologies, masses, and renal vascular pathologies, and to impede complications which occur during retroperitoneal vascular surgical procedures. These are a few of my references. Thank you.
Thank you, Vinay. Now, question called.
When you are explaining the development of the way diagram, that would have been more impressive for all of you. You can't imagine a proper
Great diagram.
yes, that's what I mean. When you want to have development and anatomy part, you have to demonstrate in the right. And the better use the background with the white.
Yes, sir. Incidental findings. Patient came with complaints of chronic abdominal pain, for which CCT was done. But then we noticed there are two renal veins, one running anterior and one running posterior to the aorta. No, sir. It's an incidental normal anatomical variant, sir. Wherein the use of this is when they are operating for retroperitoneal surgeries. A surgeon should be informed about this because as it was informed, the anterior renal vein will be easily seen, thinking that it is a normal anatomy. But the retroperitoneal, the excess or the anatomical variant generally runs caudal inferior to the anterior part, which a surgeon might miss and think it's a normal anatomy. And during surgeries, there are more complication of bleeding and all. So it has to be. Yes, sir. Yes, yes.
We think of only normal variation, normal variation, unlike in hepatic variation, it's not for variation.
Thank you, sir.
Thank you, everyone. All present, your presentations were very good. Discussion was also useful. Thank you once again.
Before we end our session, I would like to thank Dr. Talikuti sir for chairing the session. Thank you, sir. And I request sir to hand over the certificates to all the participants. Dr. Tanmay.
Unmute, speaker.